like Dr. Bharati Patel. She is known for her works in the field of medical fraternity, and she is a gold medalist from Government Medical College Miraj from in 1982, and she is a pioneering and formation of an independent maternity hospital and IVF center in Pune. Doctor has helped more than 10,000
Hello,
couples
Dr.
to
Somesh.
conceive. Yes, ma'am.
Hello. Hello.
Hello. Yeah,
First,
yeah, ma'am.
first
I can hear
slide
you,
is
ma'am.
actually, yeah. Can you see my first slide? That is my
Actually,
introduction. So that will be easy for
yes,
you.
yes, ma'am. Okay, okay, ma'am. Actually,
Yeah.
Dr. Bharati Patel is, yeah, yeah, sorry, ma'am. Yeah, she is an HOD of Sri Hospital, Pune, and IVF consultant, Nova Fertility, Pune. And she is a national vice president in IFS and national vice president of Foxy in 2016. And she was president for POGS 2018 to 19 and past president of IMA Pune. And she is the chairperson of Clinical Research Committee, Foxy, and she is a national corresponding editor for Indian uh, Obs and Gynec Journal 2012 to 2016, and she is a founder and chapter secretary for Maharashtra chapter, IFS executive editor for Journal of FSR, and she have a fellowship guide for a postgraduate reproductive medicine and a fellowship in IFS and ICOG. And she got Pune Women Icon for 2014, and she also got Foxy Star Award for 2016. And she is an inspiring gynecologist of India, awarded in 2018. And
Thank
with this, madam, I sincerely thank you for giving us your valuable time. And madam, with your permission, we have a short 1 minute video of Shield Connect launch, which is a
Okay.
digital
Not a problem.
platform for the HCP patients. Yeah,
Not a
Chitrakala. Yeah, Chitrakala, could you please play that? AV?
So should I stop my share?
Yes, ma'am.
ఇక్కడ hello, audio is not coming, madam.
Hello. We lost again.
No, no, ma'am.
Hello.
Yes, and we have a Shield Connect web page. This is a Shield Connect web page. Shield going forward with the scientific innovation, and also this is we have created a one platform, digital platform for the HCP as well as the patients. And we have all the webinars that were in the past as well as the upcoming webinars. So with this, I thank you, ma'am, for the giving us the time. And madam, over to you. Hello. Oh, hello.
I'm just, yeah, I'm
Yes,
just
ma'am.
sharing the screen.
Okay, ma'am.
Are you able to see my screen, my
Yes, ma'am. I
presentation?
can. I
Yes,
can see you. I can see the screen, ma'am. Desktop, not the presentation.
Now, still not?
Now
Hello?
we can see. Yeah,
yes,
yeah,
I'm
ma'am.
seeing, ma'am. Your presentation is visible, ma'am.
Yes.
Good evening, everybody. And at the outset, I would like to thank Shield for this opportunity to connect you all people through this webinar. We know COVID 19 was a very tough time for us, a pandemic, but it has given a new life altogether, a new way of life, and that's how we have been getting connected with now webinars, and we are closer to each other from far distance. So this is an opportunity. So whenever your mind is unstable, you feel any situation is a troublesome situation, but when your mind is stable and calm, then any situation becomes a challenge and you overcome that challenge. This is how we have now all come through the stage of pandemic COVID to today non COVID stage. So this is the way we are also going to face in infertility management. Many troubleshoots are going to be there. So how do we approach to improve our all troubleshoots in the infertility management? That will be today's all talk about. So accurate detection of underlying reproductive abnormalities is very important for the individual management decision. And once you individualize the management decision, your treatment outcome will be maximum. So clinical evaluation, four categories are very must. You must know semen analysis, assessment of ovulation has to be there. Uterus and tubal evaluation should be done by HSG or sonography 3D, and ovarian reserve assessment has to be done in any patient. So if you have not done, please basic things has to be underlined, and these four categories has to be completed before you start anything for the infertility management. So today is going to be a clinical situation like troubleshoot, first troubleshoot, how it will be. So 24 years female comes to you with married life 2 years, primary infertility, contraception is not been used. Menstrual history since she is irregular 30 to 45 days, duration 4 to 5. Coital history is okay. Menstrual cycle is irregular. Bilateral ovaries on the sonography shows polycystic ovarian morphology, and thus her hormonal profile comes FSH 6.39, LH 4.27, prolactin 13.16, TSH 2.5, and AMH 5.6. So it's very obvious now. We know that we are dealing with the patient of polycystic ovarian syndrome or a disorder. HSG shows tubes of wine, both sides there is a spill, uterine cavity normal. And comes to the male parameters, 28 years again, no addiction. Looks physically, physical appearance is okay except viscosity +2 and liquefaction time is 40 minutes. 130 million count, 85% motility, and morphology is 41. So normozoospermic. We are dealing with normozoos. So a very typical patient comes like this. You straight away go and jump because the tubes are fine and she has been PCOM, ovulatory disorder, and in these patients we plan the patient especially for COH with IUI for 3 cycles. So this was been done for this patient in some other centers. The IUI cycles were been planned for her, and this is how she goes the first IUI cycle. And first IUI cycle, her follicular monitoring comes like this, and follicular monitoring, right ovary no cyst, left ovary no cyst on the day 3. That is the basic scan. And then onwards, 8th day, 10th day, 16th day, and 19th day, she's been followed. but no follicular growth is been seen. In spite, she was been taken Letrose 2.5 milligram for 5 days. Looking at her follicular monitoring chart, it is showed that 19th day the doctor had abandoned the cycle and the endometrium was 5 millimeter. So this was her first IUI cycle follicular monitoring. So a naturally question comes, if suppose patient comes like this, how would you proceed with the second cycle? So second cycle, again you think of either increasing the dose, or you jump over the different types of molecule altogether, or you may add into the gonadotropins, or maybe you will start adding something on the PCO. So here the step up protocol was been decided for this patient. Letrose was given 2.5 milligram on day 2, 1 tablet, day 2, day 3, 2 tablets, then day 4, 3 tablets, and a 4 tablets. So altogether, this was the step up protocol for IUI. So increasing the dose. Why was it doing the concept behind increasing the dose? She was a PCOM patient and she did not respond to only mere Letrose 2.5 milligram. So probably her threshold is very high. So you increase the dose. So this was the logic behind increasing the dose. Look at her follicular monitoring. What happened with this increasing the dose? So this was the first troubleshoot. Like whenever you see a patient of PCOM and you naturally try 2.5 milligram letrozole for that patient, and she doesn't respond, that is your first troubleshoot. So how do you overcome the troubleshoot? You may be thinking, you should be thinking that this should be a high threshold patient, so you increase the dose. So increasing the dose, what happened? Patient was on day 7 13.7 millimeter follicle, 5.4 millimeter endometrium, and on day 14 she had a very good follicle, that is 18 millimeter follicle, and she had endometrium 6.6. Somehow endometrium was not reaching to 7 millimeter, so this was not very good sign, but still the follicle was very good, and the first time she could ovulate, the trigger was been decided by looking at her follicular blood flow indices, and on the 16th day IUI was been done. Now luteal support for this patient was given tablet dufastron dydrogestrone 10 milligram 3 times a day for 15 days, and unfortunately, even though everything was been done properly, she was been ovulated, the pregnancy test came negative. Now this is your second troubleshoot. So what has to be done for this patient? Are you going to jump for the third cycle, or are you going to intervene, or are you going to look back again and audit yourself what has gone wrong in this patient? How can I optimize this patient to get the better pregnancy rate for the third cycle? So what are the common errors what you think that we have done in this patient? So audit yourself. What were the troubleshoots? What was the problem with this patient? Semen analysis, number 1. What was the interpretation? Everything was been fine, but look at the viscosity and a liquefaction time, which was been almost 40 minutes. Now whenever you do IUI for this patient, hurriedly that embryologist may syringe this, because the liquefaction is 40 minutes. The patient is going to doctor is going to wait for the IUI, so immediately she will start. The moment she starts syringing, she or he, it will start giving you reactive oxygen species more, and these ROCs are going to affect your pregnancy rate. So this was the first troubleshoot. You have to understand what has to be done for this. PCO patients are not all patients same. PCO patients are different categories. All PCO patients should not be put into one basket. PCOS has to be subtyped, and accordingly you have to start their stimulation protocol. PCOS patient could be hypoestrogenic or a hyperestrogenic. Like whenever you see a patient who has got a low FSH, so that patient has a hyperestrogenic, like for example, or for simplification, obesity. And the moment patient is obese, she is a hyperestrogenic patient. Now patient who is a thin patient is a hypoestrogenic patient. Looking at these different phenotypes, you have to understand and tailor made the protocol for the patient. Look at their antral follicle count, look at the stroma, whether she has a hyperandrogenic or she is a normoandrogenic. So this is the different way PCO has to be subtyped. Same protocol was been given, only the dose was increased, the endometrium problem remained the same. The first time also she had 2.5 milligram, but endometrium was 5 millimeter. The second time it increased the dose to 20 milligram, but her endometrium could reach only for 6.6. That means that was a not very good protocol for this patient. Luteal support should have been thought little different, because when the endometrium was 6.6. So what next? Usually gynecologists, what they do, laparoscopic ovarian drilling, because that is the only easiest way to handle the patient. But remember, number one, the patient was ovulating. In spite of maybe she was getting a little higher dose, but she was ovulating. There is no role of laparoscopic ovarian drilling. Second thing, look at the laparoscopic ovarian drilling whenever the AMH is more than 6 or 7, not less than 6. 3.5 to 6, you are not supposed to touch that ovary, otherwise this is going to go into premature ovarian failure or insufficiency. Menstrual cycle irregular, pattern has to be seen. Is she having a regularly irregular cycle or irregularly irregular cycle? Then your stimulation protocol would be changing. So look at the patient's ovaries by 3D. So no, uterus you should see, endometrium, AFC, ovarian volume, uterine cavity, all has to be seen. And look at her hormonal profile. When you see this patient's hormonal profile, this looks like she is a hypoestrogenic patient. Now what happens when the patient is a hypoestrogenic PCOM? You give a letrozole or aromatase inhibitor, she suppresses inherent E2 so low that the patient's endometrium will not respond well, and you will not get a very good thick endometrium for this patient. So what is the right choice? So how can you manage this troubleshoot? Letrozole or gonadotrophins in this patient, or whenever you give letrozole and the endometrium is thin, will you add estrogen to this patient, or straight away go for the letrozole plus gonadotrophin combination for this patient? You have to think about it. Optimization is required. You have not given any insulin sensitizers for this patient. Probably this patient will require Apcord or myoinositol combination. So D-Cairo combination or metformin, whatever, but optimization could be a good choice for this patient. So in this way you start thinking the next action, that is a third cycle. So letrozole may not be ideal for this patient, rather she should be given gonadotrophins to start with, because we have already experienced the letrozole. So this patient was being or maybe you will give a conventional day 2, day 3, day 4 and then do the sonography, or you can give low dose step up protocol because she is a thin patient. Optimize this patient with insulin sensitizing agents. IUI semen collection should be done in the pre-media container. That's how your liquefaction will be in 10 to 15 minutes down the line. Your luteal support could be addition of estrogen depending on the follicular number and the endometrial lining. So that would all give you a better pregnancy rate. So next line of action, what we decided in this patient, we started with myoinositol and D-Cairo combination for this patient, that is optimization. Started with the gonadotrophins, we chose low dose step up protocol, 75 units of the FSH every day from day 3. Day 7 we could see 3 follicles, that is 14 millimeter, 13 millimeter and 13.5 millimeter. Day 10 we could see 18, 19 and 19.5 millimeter. Endometrium was 7.8 millimeter, triple line endometrium. A pattern was excellent pattern. So doesn't matter even if it is not 8 or a 9 millimeter. If it is more than 7 millimeter, that's more than sufficient. We gave her the trigger 10,000 units, fulfilling all the criteria of the blood flow indices, like PSV was more than 10, RI was less than 0.5. So we gave her 10,000 HCG, or you can modify your dose here. Maybe you can give HCG 5000 units and the GNH agonist, that is called dual trigger. That's also okay. But remember, in PCOM patient, there should not be more than 3 follicles, or you straight away give trigger with GNRH agonist. So how would you decide the time of ovulation, like trigger? When to give the trigger for this patient? These are the 10 parameters. Not necessary all 10 parameters has to be looked all the time, but maximize the parameters, so that what happens, your ovulation, you could reach closer to the ovulation and you'll get a better ovulation rate for every patient. Follicle should be more than 17, triple line endometrium more than 7, perifollicular or subendometrial halo 30 to 40% cumulus presence, follicular volume should be 1.6 to 1.5 ml, blood flow indices, peak systolic velocity more than 10, RI less than 0.5, perifollicular vascularity 3/4, and all those thing parameters, if you look at them and maximize the chance of ovulation. So let's take this patient. The patient was on day 10, 18 to 19 millimeter. Endometrium was 7.8, triple line endometrium, and we could see that her RI was less than 0.5, PSV was more than 15, 85% blood flow was there. Look at this, all blood flow all around the blood flow. So timeline was to give the HCG right away. It is impending sign of LH surge. And we planned IUI with pre-treated semen and the proper technique. Luteal support was given with estrogen and a progesterone. Progesterone was given dydrogesterone, and estrogen was given 2 milligram ethinyl estradiol for 15 days, and thus the patient's pregnancy test came positive. So this was congratulations. So this is the way one has to troubleshoot the problems in especially IUI and in the ovulation induction, and especially looking at the patient's ovarian factor and male factor all together gives you a better pregnancy rate. So we go to the next case. Before that, one has to understand that technology is advancing. Individualization of ovarian stimulation, PCO, is very important. Influence of COH on oocyte and embryo quality is very important. So less is more. Look at the PCO, like these are all polycystic ovaries in morphology patient. But if you look at the right corner PCO patient's morphology, this is a better PCO patient which has got a ovulatory PCO. If you look at the patient, compare these two PCOM patients, this would be a patient where stimulation would be required very low dose, because there is a less trauma involved here. More size of the number of follicles are there, and the size is around 6 to 8 millimeter. They are very easy to get stimulated, but doesn't give a good pregnancy rate. This is a very stubborn PCO. It has got a very thick stroma, hyper androgenic patient. Follicles are only 2 to 4 millimeter. So very difficult. She will have a very high threshold. You require a high dose to stimulate this ovary. But once you stimulate this ovary, she gets a better rate. Now same here. This is also PCO, but this is 34 years old. This is how the discrete, you see here the follicular loss is there, but a very thick stroma. She would be very difficult to treat, and this patient should be going for IVF directly. So coming to troubleshoot number 2, the case number 2, 30 years, Mr. So, Mr. Balaji, hello. Anybody from the
Yes,
technical?
ma'am.
Yes,
Yes, ma'am.
ma'am. I'm there, ma'am.
Whenever time is over, please let me know, because I keep going.
No time limit, ma'am. No time limit. You can continue, ma'am.
So 30 years old patient with secondary infertility for 2 years, past history of right side ectopic, self-injectomy done laparoscopically, HSG was been done, left tube patent, ovulation studies was been done 10 times. After the ectopic pregnancy, ovulation mostly on the left side, but still the doctor did not understand why this patient is been right side ectopic and the left side continuously only on the left side ovulation is there. It was done ovulation 6 times with letrozole, 2 times with clomiphene citrate, and 2 times no drugs. All ovulation inductions are given luteal support for 15 days, but she had no pregnancy. Now look at the case history very properly and you will understand that no pregnancy is a very big troubleshoot for this patient. In spite of she proved the pregnancy, that is ectopic pregnancy, and she's continuously had ovulation stimulation protocols only on the left side stimulation, and all the drugs have been tried. Now what next? Semen analysis, 6 ml volume, 45 minutes of stimulation. So somewhere you should start getting trouble in mind. 6 ml volume is a hyper volumia, so that is, it will get all diluted her count and everything. 60 millions and then 40% motility, progressive motility, 10% abnormal, that was fine. Patient was referred directly for IUI after the giving HCG by the local gynecologist to us. So what do you think that common error must have happened in this patient? Like, you must start thinking that you, if you want to give a pregnancy to the patient, you must start thinking what is going wrong with this patient and how can I overcome this. First thing, common error, hormone parameter was not been done. In spite of thin endometrium, CC was been added. Like, first it was been given letrose and the endometrium was thin, and second cycle stimulation by CC is going to be useful for the patient. Follicular monitoring is corresponding with the endocrinology of the patient. Ovarian reserve analysis is not done, that means hormonal parameter is not done, AMH is not done. Male factor 6 ml volume, high viscous sample, and still there is a timely intercourse for 10 cycles. So this is something not very good, and these are the troubleshoot. Look at the follicular monitoring, all the reports over here. If you look at the report, it is 19 millimeter, endometrium is 8.3. This was the letrozole cycle, and then it comes to the 7.1. This was again the letrozole cycle. So every time she's been on the left side, left side, left side, and here the endometrium was only 7 millimeters. Still there was a CC was been given. With CC again 6.6 millimeter endometrium. Look at the left ovary only one follicle is been going on. And if you look at here, the progyno was been added over here. So this is how many cycles have been done for this patient. So when I looked at the patient came to me, I started looking at a transvaginal sonography. What we found, uterus was retroverted, retroflex, normal size, fine, with 2 small fibroids, that is also fine. Endometrium was thin but trilaminar. The pattern was very good of this patient. Right ovary was very small, almost not seen. So it's gone. And the left ovary also was very small. She had antral follicle count only 2 to 3. Pouch of Douglas normal, and I did up AMH, and to my surprise, or you can say maybe we expected that by looking at the ovary, her AMH was 0.7 nanogram per ml. Now it is very obvious she has been failing, her ovaries failing. She has no follicles, and we have been trying timely intercourse for her for long time of period. May have been devascularized, and that's how the right ovary is almost gone. So right time decision or time understanding of this patient going into it very important. See, look at the this thing, folliculometry. Endometrium was thin but triple endometrium. But ovary was almost one side was not seen, another side was only 2 to 3 antral follicle count was there. So it was, we advised her IVF ICSI immediately. As this next cycle, you need to go for IVF ICSI. We have no option at all. The patient agreed, and we went ahead with IVF ICSI. We got 3 follicles for her, three eggs for her, and those all three were M2. They fertilized properly, and out of those three, we got only one embryo could go for blastocyst. Now the decision was again to be transferred the same cycle or freeze on, then transfer in the next cycle, or pull the embryos and then go ahead. Patient opted to go ahead directly, one embryo to be transferred. And I think 8 days back only her beta SCG came something around 2700, and we could see a single gestational sac uterus. So this was the troubleshoots how we overcome in that patient. Now coming to the third patient, again 23 years old patient, 2 years primary infertility, never used any contraception, BMI 20, menstrual history quite regular, coital history normal, hormonal parameters. So don't forget to advise hormonal profile of infertility. FSH 7.20, 5.45 LH, prolactin 15.8 nanogram per ml, TSH 1.6 and AMH 2.8. So very obvious, she has got a hyperprolactinemia 50.8. So sonography shows uterus normal size, anteverted, anteflexed, right ovary AFC 8, AFC 9 on the left ovary, uterine cavity normal, bilateral tubal spill was there. On the male side, everything seems to be fine, except the patient has no sperms. Appearance wise, everything, viscosity, everything normal, liquefaction was okay, but there was no sperms at all in this patient. So what is the next step? So moment you see the patient who has azoospermia, don't jump to a conclusion dogmatically that the patient has permanent azoospermia. So always remember to repeat the semen analysis after 15 days or 8 days, but not repeating the same way. The repeat the semen analysis by centrifuging the sample with 3000 rpm for 15 minutes, and then still if you don't see in that pellet sperms, then label the patient as azoospermia. Once the patient is been labeled or diagnosed as an azoospermia, don't leave them immediately there or don't advise them for the donors. Look at their hormonal profile. So what hormonal parameters you will do for the male infertility or azoospermia? FSH, LH, serum testosterone, serum prolactin and TSH. This is at least minimum 5 tests has to be done, hormonal test, for any patient who has been diagnosed as azoospermia. FSH was 37.10, LH was 18, testosterone was 157, prolactin 15.9 and TSH was 0.9. You know very obviously this is a hypergonadotropic hypogonadism. Now in these type of patient, go ahead and do the sonography to understand the ovary, how is the epididymis, how is the vas, and then look at the pampaniferous vessels on both sides, and then you come to a diagnosis. It is non-obstructive azoospermia. Now once the non-obstructive azoospermia comes, again don't jump to the conclusion that nothing is going to happen, you are not going to do her IVF ICSI, but we have to go for a Y microdeletion for this patient, because sometimes patient wants their own child. So if you go with a Y microdeletion, you will see the AZF region, and in that AZF region you should see A, B and C. So in this A, B and C, suppose she has got a C pattern, this patient will have a 50% chance of TISA success, and the frequency of deletion will be 75% AZFC. Versus if the patient has got AZF A deletion, so that will be virtually zero success rate. This patient will go donor directly, there is no option only. And if the patient has got AZFB microdeletion or the deletion type, 10% of the patients will have this problem, and that will again have no option but to go for the donor. So maximum patients with azoospermia, when you do a microdeletion, you will find 50% of them, 75% of them will have AZFC deletion, and that has got a better outcome even if you have a non-obstructive azoospermia. You can go for micro TC, and these patients may have focal spermatogenesis. So we did this all things, and we coming to our diagnosis of primary reticular failure. We discussed with the patient pros and cons of this all. Patient counseled regarding the focal spermatogenesis and chance of sperm retrieval through TISA and IVF conception, but patient opted donor IUI. Now you have to value patient's options or patient's consent. So donor IUI was been done. Now, female partner young, ovulatory cycle, normal tubal factor, normal ovarian hormonal profile, prolactin was been treated. So, this patients how you go ahead for donor. So, this is your troubleshoot, or you have a infertility patient scenario. So IUI cycle started with letrozole because my resident jumps only straight for letrozole. They like letrozole, and nowadays letrozole is the first line of management, so everybody jumps on that. 5 milligram daily given, 3 to 7 days. Follicular monitoring, dominant follicle on day 12, 20 millimeter, good. Trigger was given by injection HCG 5000 units. Phenotype matched cryopreserved sample thawed. IUID was been done. Luteal support was given with a micronized progesterone 200 milligram daily for this patient. UPT negative. Now this is not done. A patient who is being so normal female, and you've been taking the sperms from a donor, good sperms, probably UPT should not come negative for this patient. So we have to be very serious about this patient IUI donor. So we must think what common errors might have happened in this patient. So audit yourself, troubleshoot the things, and then go ahead for the management. Ovulatory patient, no need of stimulation. Probably you don't require stimulation for this patient. Letrozole is effective for CC resistant PCO more. So there is no need of direct starting letrozole. Probably she is hypoestrogenic and that will not work. No need of luteal support for this patient, or you have to do a serum progesterone day 9 after the IUI or after the ovulation, and then see whether luteal support is done or not. So we next cycle we planned natural cycle or the gonadotrophin. So we thought maybe patient is young and she did not wanted multiple pregnancy at all. We started a natural cycle. On day 8, follicular monitoring showed 15.5 millimeter, endometrium 7, which is very good. Day 10, 17.5 millimeter, endometrium 7.2. Bit slow because we were expecting day 10 she should be 19 millimeter, but it's okay. Day 11 you follow because this is her natural cycle, she may respond differently. 18.5 millimeter endometrium, 7 follicle, and endometrium was 7.5. Please still look at her blood flow. Wait, because 18.5 is not the end point. Blood flow indices were still not matching. Peak systolic velocity was 8, RI was more than 0.5, blood flow was 45% only. So we waited till day 12, and day 12 it was 19.5 millimeter, endometrium was 7.8, and the blood flow parameters were improved, but that not to that extent. So we still waited. Day 13, 20 millimeter follicle, 8 millimeter. Look at it. This is the way it has been going beautifully. Peripheral blood 70 per ES was 12. I was less than 0.4. Excellent. Give trigger. Maybe you give dual trigger here. That will wonder. And because those days we used to give SCG 10,000, but now we are giving oral, that is recombinant SCG 250, plus we are GNH agonist 2 milligram subcutaneous, that is called dual trigger. Excellent results I am telling you. Start and change your practice. For IUI was been done, donor selection was been done, good parameters twice. We thought maybe we will give a donor, it is 24 hours and 48 hours. No luteal support was given to this patient because we had not done anything to this. No stimulation was given. So why luteal support? But serum progesterone was been done on day 9 because somehow I was thinking that I should not miss the bus at all. And day 9, when we did 9 gram per ml was her serum progesterone. That's how we added her support micronized progesterone 200 milligram twice a day for next 8 days. And then we did her after 15 days UPT. UPT was positive. She continued the support till her FSH was positive, and very good pregnancy follow was done, and she had a very good life EG. So this is how you start looking at the patient when it is a azoospermia. So I think it is 6:25. One more case we can take, and then maybe I think we can stop. Is that okay, organizers?
Yeah, madam. Yes, madam. Yes, madam. Please go ahead.
Yes, ma'am.
So this is a fourth one. Situation is three. It is only written fourth one. Now we are on to the fourth case or the fourth troubleshoot. Mrs. Ek, 25, 24 years, 3 years, primary infertility, never used contraception, BMI 22, cycle regular, 28 to 30 days, 3 to 4 days normal, coital history normal. Look at her menstrual cycle, okay, ovulation on the 14th day, hormonal profile 4.2 FSH, 2.4 LH, 21 prolactin, quite okay. All is okay. Looks like patient is absolutely okay. And then go for the sonography. Once you do the sonography, unless you do the sonography by yourself or a good sonologist, your history doesn't complete. So uterus normal size, anteverted, anteflexed, endometrium good, right ovary endometriotic cyst 2.1.5 centimeter, small one, but there was a endometriotic cyst. Left ovary was normal, HSG was uterine cavity normal, bilateral tube was tubal patency was there. Semen parameters, everything was normal, normozoospermic according to WHO type 2 there. So no any treatment was being taken for this patient. So in the view of ovulatory cycle, patent tubes, no obvious pelvic anatomy distortion, young age, married age 3 years, normal male factor, endometriotic cyst less than 4 centimeter. This is the way you have to do your patients. Why you have been doing? You should justify what treatment you are giving to the patient. So 10 to 15 patient to 25 patient, you write it down, and then onwards automatically you will start understanding in the view of 1 2 3 4 5 6 parameters. So these are the my parameters. Because of that, what I would decide the patient 2 cycles of IUI with controlled ovarian hyperstimulation. Why I am deciding this? Because the ISHRE guidelines, they say we are not supposed to downregulate the patient, medical therapy should not be given to the patient, and active management of infertility should be given to the patient when you diagnose the patient of endometriosis. Maybe this is mild to moderate endometriosis, but the endometrioma was less than 4 centimeter. So differentiate the patient between anovulatory patient and the ovulatory patient, and start giving the ovulation induction protocol. Whenever there is no ovulation occurring, you need mono. When ovulatory patient, you need a super ovulation. You will increase the chance of pregnancy with the more eggs. Now with this patient, we thought we should start with the clomiphene citrate 100 milligram 2 to 6. Not all patient is aromatase inhibitor. Clomiphene citrate also has a role to play in every infertility management. This patient was decided to give injection HMG 150 milligram day 4, day 6 and day 7, day 8. Follicular monitoring was done. Day 12, 2 follicles 19 and 19.5 millimeter follicle was to be given. Trigger was given with HCG 10,000 units, or as I said, dual trigger can be given. IUI was been done on the day 14th. ET was 9.9. Semen preparation was done with swimmer, post-wash 50 millions and 100% motility. Luteal support was given with micronized progesterone 200 milligram twice a day vaginally. But unfortunately UPT negative. So it's a common scenario. It happens with everybody. Every patient and every infertility consultant or a gynecologist, you face this. But don't leave the patient there, because this can happen. What can be the reason for failure? Try and understand, audit yourself. and then this is how the troubleshoot should be managed. How will you plan this patient for the next cycle? Patient comes to you, that's fine. If the patient doesn't come to you, still you should know what can be done for this patient. So reasons for failure of IUI. This is a patient of endometriosis. Poor quality oocyte number 1, sperm inactivation number 2, increased DNA damage, sperms, oocyte and embryo. That's how it decreases the fertilization, low grade embryo formation, reduced implantation and inflammation at the peritoneal and the follicular level. So reason the patient, tell the patient these could be 4 reasons why you may not have conceived in this cycle. So coming to the second cycle, we stimulated with letrozole 5 milligram, 3 to 7 days, because first time when we gave her CC with HMG, this did not work. So we started letrozole with FSH, highly purified FSH, or you can give recombinant. Follicular monitoring done. Day 13, 3 follicles again, very good. Trigger was been given. Day 14, we did IUI. Luteal support with dydrogesterone this time was given 10 milligram because endometriosis needs an immunomodulation. So that was been given 10 milligram 3 times a day, and this was actually when we we published our Lotus 2 trial, and we realized that dydrogesterone plays a very important role in the luteal support, and that gives a better pregnancy rate. Still the pregnancy test was negative. Now this was a very big dilemma or very big frustration. What is the cause of failure? Is it that rupture? Yes. She had not ruptured but only collapsed follicle both the times. Poor fertilization and poor embryo development could be another reason why she is not conceived. So what is the role of laparoscopy after 2 failed IUI cycle? This you should think about. So patient posted for operative laparohysteroscopy according to the ASRM revised classification of endometriosis. She had grade 1 mild to moderate endometriosis. Adhesiolysis was done with fulguration of endometriotic spots. Bilateral tubal patency was in there. Post-op injection leupride depot was given 3.75 milligram. This is for down regulation. In the view of mild to moderate endometriosis, young age, good ovarian reserve, removal of inflammatory focus, patient was being down regulated. Patient planned immediately IUI less than 3 months from the surgery because this is called active management of infertility. Patient was stimulated straight away with the gonadotropins HMG. Now no FSH, we know 100% she has endometriosis. You need LH as well as FSH. HMG 150 daily monitoring was been done. 3 follicles 19, 20 and 19.5. Trigger was given recombinant HCG now. And plus GNH agonist also was been given. IUI was done on day 14, 9.9 endometrium. But this time luteal support was totally again different. Dydrogesterone, but we gave 20 milligram 3 times a day. This is a new study which has come. If a patient of endometriosis, you increase the dose of dydrogesterone or the luteal support, it acts as an modulator, anti-angiogenic, and the progesterogenic activity is likely to be better in the patient, and the UPT was positive. This is the how we should be tracing the patients. You should be behind the patient why it is failed. Go for each small troubleshoots and start correcting them, and that's how you are going to get the pregnancy. So thank you very much. Any questions, I'll be very happy to answer.
Yeah, thank you very much, madam, for your excellent talk. It is always an honor and learning to hear you, ma'am.
Thank
Madam,
you.
yeah, if you allow me, then we will have a Q&A session. So I'll read
Yes.
out the questions in the, from the chat box.
Yeah, sure.
Yeah. There is a question that if a patient is undergoing for a bariatric surgery, how
Mhm.
much time should a woman wait for get pregnancy
If
or for fertility?
the bariatric surgery, I think bariatric surgeon, my husband being the pioneer in bariatric surgery, 1 year, they say 1 year they should wait because their stomach is, because if they have done the partial gastrectomy, the stomach portion is been very small, and In the pregnancy, the nutritional deficiencies could be little higher, and she may again go back to her, weight gain. So 1 year is the time period.
Okay, ma'am. Thank you, ma'am. And we have one more question, ma'am. What is the ideal approach for a CC resistant uh, pregnancy? I mean, the infertile woman. Yeah.
CC resistant patient is a PCO patient. Now, as I told you, there are four categories of the polycystic ovarian morphology. Look at them and see whether which type of PCO she is, whether she is hyperandrogenic and a very stubborn small follicles 2 to 4 millimeter. This type of patients will require a high threshold and a high gonadotropins to start with. If suppose she has a number of follicle more and a thin stroma, this she will require a low dose of gonadotropin. So to begin with, CC resistant PCO patient, start with letrose aromatase inhibitor, that is 5 milligram, not 2.5 but 5 milligram for 5 days, and see how she is responding. If her endometrium is good, her weight is okay, she is not hypoestrogenic, that patient should get stimulated. And optimize
Thank you,
the
ma'am.
patient, optimize with insulin sensitizers. And in the insulin sensitizers also, don't give a half-hearted dose. Like in the capsule form, if you take, they don't get the enough dose. Like how Shield has got that Epcot sachet, that is the only ideal way to give enough amount of insulin sensitizer to the patient. Because of that, we don't get the results in the patient. So you must give in the powder format so that they get the enough amount of myoinositol or insulin sensitizers to get a good outcome of the follicle or stimulation. Yes.
Yeah. Thank you, ma'am. And we have one more question, like when to prefer testicular biopsy?
Yeah. uh, Patient, suppose if the patient has azoospermia and the patient's FSH is less than 5 or 5 to 10, of LH is something around 2 to 5, that means the patient has got a good chances of having the sperms. Epididymis is okay, the testicular volume is fine. In those patients, you go for the testicular biopsy. Here you know that you will find the sperms, and you can give the chance to that couple to conceive for their own child, own with their own gametes. So whenever where testicular volume is good, her FSH, his FSH are low or normal, and LH is also normal or low, and they have a good epididymis, turgid epididymis, this patient should undergo the testicular biopsy.
Yeah. Thank you, ma'am. And there was a appreciations comments from Dr. Vidushi. It was a pleasure listening to Dr. Bharati, ma'am. Thank you for your consistent guidance and brushed up my infertility practice, ma'am.
Vidushi is
Yeah.
a very dear friend and very good fellow, very intelligent fellow, and she is doing a very good practice at Dehradun. Uh, she's a bright gynecologist and infertility consultant. She's doing good. Thank you, Vidushi.
Yes, ma'am. And madam, I think I don't see any no more questions
Okay.
uh, in the comment box. So if you allow me, then we will close the webinar.
Yeah. So I think thank you very much. And in case they have the questions later on, also my mobile number is there with them, or they can contact you and you can contact me.
Yes,
No
ma'am.
problem.
Sure, sure, madam. And thank you once again, madam.
Thank you.
It was very our privilege and honor to have you in our webinar. And all the audience, many thanks from the Shield team.
Yeah. Thank you very much.
Thank you.
Yeah,
Thank
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 you
you,
very
ma'am.
much, doctor. Thanks a lot.